I should turn that on, huh? Good morning, everyone. I'd like to extend a warm welcome to the Indian Health Service Director, Rosalind So. Thank you for your leadership at IHS and for being with us today to discuss the administration's fiscal year 2025 budget request. We were all really looking forward to Congressman Tom Cole joining us today in his new role as the full committee chair. However, the devastating tornadoes across Oklahoma have required that he stay back in his district, and without objection I ask that his prepared remarks be included in the record. Chairman Cole is the first Native American to ever chair the Appropriations Committee, and as he made it his legacy in Congress to advocate for Indian country and ensure that tribes receive the resources they need to take care of our communities, of their communities. Under both Republican and Democratic leadership, this committee has continued to prioritize and support health care services for American Indians and Alaska Natives. And as you look across here, we have Chairman Pingree, and we have former chairman of this committee, Betty McCollum. Ken Calvert was chairman here. All of us have put a priority on Indian health services and the needs and trying to keep our treaty responsibilities that we have. I have no doubt that Chairman Cole will continue to advocate this critical bipartisan effort as he leads this committee. There is no one better for that job, and I, as well as Ranking Member Pingree, stand by ready to help. In the 2023 Congress provided advanced appropriations for Indian Health Services for the first time, and I will say that that was because of the tireless work of Chairman Pingree at the time, along with the rest of the committee, but she was the leader in making sure that we got that done, and I thank you for that. Advanced appropriations provided the Indian health system with the certainty needed to properly serve communities, provide stability for healthcare providers, and improve long-term planning for services, even during continuing resolutions and government shutdowns. I know this funding does not begin to meet the full need, but it's a step in the right direction, and it's a signal of our understanding and commitment to upholding our trust and treaty responsibilities. For fiscal year 2025, the President's budget requests $7.96 billion in discretionary funding for IHS, a 14% increase over FY24 level. Notably, the request does not include advanced appropriation, but instead requests that all funding for IHS be moved to mandatory starting in FY26. I will continue to advocate to provide certainty to healthcare professionals and programs in Indian country, but I do have some technical questions about shifting IHS programs to mandatory. So in the meantime, I look forward to hearing how advanced appropriations can continue to support planning and operations of IHS programs. Director So, your leadership at IHS is vital to not only upholding our trust and treaty agreements, but ensuring adequate and accessible health care to all tribal members. Thank you again for joining us this morning. I look forward to our discussion. Now I'd like to yield to Ranking Member Pingree for her opening statement.
Thank you very much, Mr. Chair, and good morning, Director So. Thank you for being with us today to discuss the fiscal year 2025 budget request for the Indian Health Service. The Indian Health Service provides health care to approximately 2.8 million American Indians and Alaska Natives through a network of over 600 hospitals, clinics, and health stations on or near Indian reservations. With 70% of Alaska Natives currently living in urban areas, the IHS funds 41 healthcare organizations in urban areas. IHS relies on annual discretionary appropriations for its funding, and, sadly, this has not kept pace with need. The statistics on health disparities in Indian country are sobering. This subcommittee has been dedicated to finding solutions, both through investments in the IHS and through improvements in how funding is delivered, namely through the enactment of advanced appropriations. It's critical we continue our efforts. Your budget requests discretionary funding in FY 2025 and proposes a shift to mandatory funding beginning in FY 2026. Though I would note that mandatory funding is the jurisdiction of the authorizers. I am interested to understand how this would improve the health
Thank you very much again. Good morning, Chairman Simpson and Ranking Member Pingree and members of the committee. Thank you for the opportunity to testify on the President's fiscal year 2025 budget request for the Indian Health Service. Before I turn to the budget, I first want to acknowledge and thank each of you. Appropriations, IHS made 100% of payments to eligible tribes through compacts and contracts in the first 2 weeks of the fiscal year. I also appreciate the opportunity to share with you the steps I have taken as the IHS Director to improve transparency, accountability, and oversight of the agency. As we seek additional funding and new funding authorities, it is crucial that the Indian Health Service improve its internal operations to ensure safe, quality health care and protect and support its relationships with tribes and urban Indian organizations. To ensure that I fully understand the challenges and accomplishments throughout Indian country, I value the opportunity to visit with tribal leaders across Indian country to gain their input and perspective. To move the Indian Health Service to a high-performing organization, I implemented the first agency work plan in January of 2023 that achieves 3 major accomplishments, including total system safety strategies, the IHS patient safety policy, and improving purchase and referred care program, such as establishing new medical priorities, establishing a financial monitoring system, and staff training to obligate PRC funding in a timely manner. Our 2024 agency work plan outlines steps the IHS is taking to address priorities as well as mitigate risk. The agency work plan addresses a wide range of issues, including patient safety, human capital, operations, finance, and compliance. This work builds on our effort to meet the GAO's criteria for removal from its high-risk list. With your support, the IHS budget has grown 69% in the last decade. We know this type of growth is challenging to accomplish in a constrained discretionary funding environment. Over the years, the work that with our tribes and urban partners underscore our shared goal to improve health outcomes for all American Indians and Alaska Natives. With this shared goal in mind, the administration acknowledges the 2025 budget request for our Indian Health Service. We know that despite our shared efforts, IHS is still underfunded. This underfunding of the Indian healthcare system directly contributes to the stark health disparities in our tribal communities. American Indians and Alaska Natives born today have an average life expectancy that is 10.9 years fewer than U.S. all races population. Long-standing health disparities were complicated by the pandemic, with American Indians and Alaska Natives experiencing disproportionate rates of COVID-19 infections, hospitalizations, and deaths. Addressing these inequities is a moral imperative for our nation, and it will require bold actions from all of us to ensure we are upholding our commitments to Indian country. That is why the budget proposes to build on the enactment of advanced appropriations by funding the IHS as discretionary in fiscal year 2025. Beginning in fiscal year 2026, the budget will move to all funding to IHS mandatory. The administration continues to stand behind mandatory funding as the most appropriate long-term funding solution for IHS. We know it's a significant change that will take time and collaborations with Congress and tribes to accomplish. We believe that a change of this magnitude is overdue and we must deliver for Indian country. As we work towards securing stable, predictable, and adequate funding to meet the needs of Indian country, we are committed to working closely with our stakeholders. Again, thank you for the opportunity to speak with you today, and I'm happy to answer any questions the committee may have.
Thank you, Director. Let me ask a couple questions first. As I said, Chairman Cole was looking forward to being here today and wanted to ask about changes to contract support costs, and he asked me to ask a couple questions, so I'm going to ask those so that I don't forget because he is my chairman. How does the IHS plan to go about developing an accurate estimate for the tribal contract support costs that are associated with tribal third-party funded operations serving Native American patients and other IHS beneficiaries? Will there be tribal consultation involved?
Thank you for that question. Absolutely, we have to integrate tribal consultation into any work that we do at the Indian Health Service, particularly of this magnitude for CSC on third party. With regards to that, IHS already has established methodologies for calculating CSC today. And so we're building on that to try to make sure that we incorporate what our strategies will be, depending on the decision that is forthcoming from the Supreme Court. So we are prepared to have those conversations as soon as possible with tribes as we move forward.
Okay. We've both consistently heard from tribes about critical problems resulting from staffing issues across Indian Health Services, especially in the purchase and referred care program. Director, what is IHS doing to address staffing shortages and the subsequent problems, delays, and financial impacts resulting from these shortages? And what barriers to hiring and retaining employees has IHS identified, and what is being done to address them?
Thank you again for that question. If there's one thing that keeps me up at night, it is our workforce. How fragile it is today, that's the same thing across the nation in our healthcare system, that we are all being stretched to the limits with regards to staffing. At the Indian Health Service, I've taken great efforts to try to address this issue. Some of the examples that we are doing right now, as I see the challenges growing every day. I was out in Indian country last week and heard from one healthcare facility where we have 17 vacancies for pharmacists. And we know the value of our pharmacists as the work that they do in any healthcare facility. But in IHS, pharmacists do a lot more than go beyond just dispensing medication. They actually do patient care. So in this particular space, having those kinds of vacancies creates this risk that we're talking about, and we have to get in front of that. I have been working very closely with the Commission Corps, the Public Health Service at HHS, to make sure that we maximize all of these resources that could come to Indian country as we move forward, and taking strategies about how do we keep the staff that we have at the Indian Health Service. In this particular space, we're making some strides here with Commission Corps and making sure that, again, we have what we need. We're also taking a whole approach at Indian Health Service to streamline HR. We have 12 regions within IHS, and so before, every region is sort of doing their own thing, we're not big enough to be able to continue that kind of an operation. We have to bring our resources together, and bringing resources together to be able to address the system-wide issue that we have is critical right now. So we're in that space right now to try to figure out. And what we're learning, again, as you can imagine, that 12 different organizations trying to do the same thing, we have inequities, and we have disparities, and we have inconsistencies. So you're not building to, it's hard to understand if you're even building towards success. So looking at that and helping us to try to figure out how do we maximize resources. So in that particular one example in there is we're taking what the workload and lining it up with the workforce, instead of trying to figure out who's doing what and so forth. So building this alignment, and we did this, I used the same strategy for PRC, the same strategy for the bill work that we need to do. In addition to everything that we're doing, I have been meeting, as I shared yesterday, all of the work that we're doing for the infrastructure bill, $3.5 billion that Indian Health Service received about 3 years ago. I need 500 engineers today to complete that work. And so everybody needs engineers too, because a lot of other people got infrastructure dollars. So how do we do that? I have written a letter to every engineering school across the nation to let them know, number one, about Indian Health Service. Number two, here are the ways that we can get you into the Indian healthcare system as we move forward to do the work that we need to do. We've also looked at additional strategies there. I'm also working very closely with tribal schools and tribal colleges to let them know, again, we are a workforce that needs you. So how do we do that? So taking these different strategies and running with them as fast as we can to make sure that, again, we have to tell the story about IHS. We have to also let people know that we're simplifying and streamlining our process so it's not so complicated to come into a federal federal system. Additionally, we have looked at some administrative changes as well as we've requested A19s that help us streamline. I'll give you a couple examples in that space. That with regards to loan repayment, for example, or scholarships, if you look at within just HHS, you have IHS that has a loan repayment program, and then you have HRSA that has a loan repayment program. HRSA's money is not taxed. IHS's money is taxed. So if I'm an applicant, I'm probably going to go look at HRSA first because I don't have to, I'm not going to be taxed. So these kinds of discrepancies and these kinds of inequities continue to minimize our efforts and our work at Indian Health Service. And then lastly, there are authorities working very closely with my partners at the Veterans Administration. They have maximum Title 38 and maximum Title 5 with respect to hiring and retention of their staff. And those are the kinds of authorities that IHS needs as well. We need to make sure that we have the ability to compete with the VA. And right now, we kind of just have our staff going from IHS to the VA, from the VA to IHS, depending on that. And that's not addressing the inequities for the people out in Indian country. So there are a number of things that we are looking at, and there are a number of things that we also know that need to be adjusted on the A19 side that will help us make some.
Yeah. I don't know what it is, but I do have one final question from Chairman Cole. Sending me a message on on that question. It's about something that both he and I are very interested in, and the development of a behavior health pilot program. We all recognize that there is a growing need to increase support for behavioral health programs in Indian Health Services. Each year, tribes are realizing a greater need to provide services for prevention, treatment, and recovery from mental health and substance abuse disorders. What can the agency do to help address this growing need, and what additional resources are needed in FY25 to ensure tribal members can receive the quality care and behavioral health services? health pilot program?
Yes, yes, absolutely. At the Indian Health Service, this is definitely an area that probably on every single day we're looking at strategies about mental health, behavioral health, but we're looking more beyond that. We look at all the social determinants of health that our people deal with. And when I travel out to Indian country, when I meet with tribal leaders, food security is always at the top of the list. Transportation, being able to get from point A to point B is a problem. So looking at all of this holistically to try to find out how do we address these issues, because particularly with patients that need mental health, behavioral health services, if there are other factors that are impacting their ability to get the care that they need, and moreover, to seek the services, our window of opportunity is so small when these patients are ready to get care. So looking at these, at all of the social determinants of health is absolutely critical. And then in this particular space is facility infrastructure. That I'm hearing from tribes all the time that yes, Indian Health Service focuses on hospitals and clinics, but those treatment facilities, those detox facilities are becoming so much more important to try to address, to get people into a facility, a facility close to their home that they can get the services that they need. So in this particular space, we know that there are additional resources that need to be had. In addition to that, we also know approximately 60% of the Indian Health Service has been contracted or compacted by tribes, which means that they have taken the resources from IHS and they operate their own healthcare system. So in that space, it makes it even more of a need there is how do we now look at the resources that we have at the Indian Health Service, and really the 40% that we have left, and then the 60% that additional resources need to be had to address facility infrastructure. We track now on a regular basis the issues that we have with opioid in our IHS healthcare facilities. And we've seen a huge reduction in that by looking at different strategies of how we can address this. On a regular basis, we also deploy services and support and resources when we have suicide clusters that we hear from time to time. So our system is now better able to address some of these things that are happening in real time, that allows us to, even in spite of the limited resources of staff that we have, that we now have teams available that can go out to any tribal or IHS healthcare facility to help with these crises that are happening. So there's definitely, the facility side is huge on IHS. We are looking at, not self-governance, but the joint venture model that has been extremely successful in Indian country. Joint venture, again, is where the tribe builds the facility and then the government staffs and equips that facility. And what can we do in this particular area, because we can't just focus on the healthcare side without looking again at the behavioral health and mental health needs. And so looking at facilities and how can we spread that to look at those opportunities to look at facility infrastructure. So there is a huge need in this area. I will also say the vacancy rates that I have at the Indian Health Service today, which is the 40% that remains, is at 40%. I have a 40% vacancy rate for mental health and behavioral health. I cannot address healthcare needs in any country with some of challenges that we have with the workforce. So it really requires us to be very creative, looking at telehealth, telemedicine, and looking at what we're learning more and more about is the community health aid program, which is a program that was born in Alaska, where we train individuals that are part of a community that can then help us strategize and be able to address the needs in each local community.
Oh, thank you for the answer to those questions. Ms. Pingree?
Oh, it's in. It's on. I'm sure that was my fingers' fault, not the machines. But let me take off from this issue about your vacancies, and thank you for explaining to us the sort of comprehensive way you're going about this. One thing I wanted to mention in this vein is graduate medical education, just as a tool to use to get more people engaged in the services. I know from other experiences that when people are able to do a residency, either related to a tribe or in the same community, you're more likely to keep them. We know, because in Maine we have a lot of issues having enough rural physicians, and so enhancing our residency program has been important. So I just want to talk to you a little bit about that. What is the Indian Health Service doing to support the development of residency programs and rotations for federal, tribal, and urban sites? Specifically, how are you working with both HRSA and Veterans Affairs on this? And what are some of the challenges that you're dealing with in trying to set up residency programs? I know it's not a simple thing, maybe it takes a long time, but just let's talk about how we could sort of move forward in that direction.
Thank you for that question. This is something also that we have leaned into over the past few months. I think it was shortly after January, I was out in Washington State meeting with the Puyallup tribe, and they have a very nice residency program there. And one of the things that I learned from that was that we weren't quite tied together like we should be or could be. So how do we make sure that, again, that Indian Health Service is embracing all of these opportunities for our students to go for residency? We also know that a person that goes through residency generally stays within 100 miles of that. So
Right.
getting them into our healthcare, getting them into these residency programs is very important. So our follow-up in that example was, how do we make sure that we are supporting, not only supporting the residency program that's operated by the tribe, but moreover, how do we make sure that we're integrated into their system so we can also look at the providers that are coming out of that facility. The same thing in Shiprock, New Mexico. We have a residency program there that we have leaned way, again, doing everything that we can to make sure that's at one of our IHS facilities. So we have a lot of visibility on that. But still, there are many opportunities out. I've been able to visit the Cherokee Nation Hospital, that or medical school that is on tribal land. And so again, what do we need to do with Cherokee Nation to make sure that we are partnering with them to get students in there, but also be able to do that? I also meet with the American Indian Coalition of medical students that do, and they have said the same thing. Going back to the A19s, one of the things that I'm hearing very loud and strong from our medical students is they want different options, like, for example, on the loan repayment. They don't want to have full-time. Can we do part-time? And so that's one of the changes that we're trying to get into. So I think really taking a step back and looking at all of these flexibilities, all of these opportunities that we need to be trying to adjust, where we have more options for providers that are coming out of school to be able to come with us. And just tied to that also is what we're calling any 2080. Any 2080 at the Indian Health Service is that in our emergency room departments, of course, a federal employee works 2,080 hours a year. So we're negotiating with our providers how they can work any 2080, especially in emergency room. That's very, very helpful. They can do it all, and there's whatever works for them in their schedule. And what I have seen as a result of COVID is our providers, not just doctors, but their priorities have changed. Probably all of our priorities have changed as a result of COVID. So what do we need to do so our system can adjust to that, so we can build in these flexibilities, get our needs met, the providers' needs met, and if they want to do other things in their personal lives and so forth. So again, trying to look at all of those things to be able to make sure that we're doing everything that we can. Very recently, I also visited Morehouse Medical School, and I was able to have a conversation with them. So I'm leaning into every opportunity that I can find and I can get to talk about Indian Health Service, opportunities out in Indian country, because there's still a lot of work that we need to do in that space to be able to make people aware that we offer them there are certain opportunities in Indian country as well.
Great. Well, we're happy to support you on that, and good for you for working and leaning into that.
Ms. So maybe take a 10-minute recess.
Testing 1 2 3 4 5 6. Check 1 2 3 4 5 6. Testing 1 2. Check 1 2 3 4 5 6. Test 1 2. Testing 1, 2, 3, 4, 5, 6, 7, 8. Test 1, 2, 3, 4, 5, 6. Chairman's mic 1, 2, 3, 4, 5, 6. One, two, three, 4, 5, 6, 7, 8, 9, 10. Audio test to the card. Testing 1, 2, 3, 4. Microphone test 1, 2, 3, 4, 5, 6. Testing 1, 2. Test 1, 2, 3, 4, 5, 6, 7, 8. Test 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Testing 1, 2, 3, 4, 5, 6, 7, 8. Testing 1, 2.
Just normal, so I can know the volumes because I took it down.
Test 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Audio test 1, 2, 3, 4, 5, 6, 7, 8.
Testing 1, 2, 3. Test 1, 2, 3. Hello, testing 1, 2, 3. You want me to raise it up a little bit, or you good with that?
I don't want to raise it.
Yeah, because they're gonna have it. Yeah. Okay. So we're good for now, and then we're gonna see the amplifier later on. Okay. But there was a cabling in the back. Thank you. Testing 1, 2, 3. Test 1, 2, 3.
back in order. Ms. Pingree, you have the floor.
Okay, thank you very much. So I want to talk a little bit about the produce prescription pilot program. We know that access to healthy food can impact overall health, especially looking at development and maintenance of chronic disease like diabetes. About 1 in 4 Native American people experience food insecurity compared with 1 in 9 Americans overall. Therefore, I helped secure funding for the produce prescription pilot program at the Indian Health Service, and I am so pleased that IHS has implemented the program with awards to 5 tribal communities to increase access to fruits, vegetables, and traditional foods in American Indian and Alaska Native communities at risk for food insecurity. So can you talk a little bit about how the program will empower and support tribal communities to build food systems that support tribal sovereignty and well-being, and what's the current plan for expanding the program, and what resources would be helpful to you? How will the Indian Health Service select additional Native communities to participate?
Thank you very much for that, and thank you for securing those resources for us. It is huge in Indian country, as I already talked about food insecurities across Indian country. What I have seen, though, and again, our partnership with USDA and bringing all resources together to try to figure out how can we support more homegrown types of foods in our tribal communities, and as of course many of the tribes understanding that food is medicine, and understanding that going back to our traditional foods is better and more healthy for us as we move forward. Using the $6 million that we receive, and certainly the awards that we have made, we're really looking at the outcomes of those 5 grants is great, but 5 grants for more than 500 tribes,
Sure.
It's hard to quantify what that is. But I think as we start to move forward and really pull all of the resources together and using the examples that are already out there in Indian country. Last year at the Tribal Nations meeting, I met with a young lady from the Omaha tribe, and just a young lady that was saying she had worked with her tribe to build out to do some agriculture and farming of their foods in their tribal community. That's what we need. That's what we need to build on. And how do we continue to do that? What we want to do is use the successes out of the 5 grants that we have to be able to tell more. As I shared, I was just at a food distribution center last week in Arizona. And what I'm hearing in that particular space, what I heard in that space was that our tribal people are choosing to get food boxes versus using their food stamps because, again, the food boxes has more value for them than food stamps. I was blown away by that because I saw the size of the food box, and that's supposed to last them a month. And so we have some serious issues here with regards to this. And then on top of that, many of those things in the food box, while they were great, were processed foods. So how do we make that adjustment here? How do we work with tribes to use what they are building, what they are farming, what they are doing in their own tribal communities, whether it's fish, whether it's beef, or any other opportunities that we have. And so in that particular example, we walked away saying we're going to put them in touch with one of our nutritionists. So at least we can help a family maybe understand how you could use this box of food to make it as healthy as we possibly can. Understanding there are still challenges and limitations. So there's a lot of work that needs to be done in this area, but there's also many great examples across Indian country that I would like to see us capitalize on. One last thing I would say, I visited a tribe in Oklahoma where they have their own grocery store. And so they get to have a say-so in what they put in those grocery stores, and then they take some of those same ingredients and then build their recipes and, tying it with our diabetes programs. And how do we build that out for everyone to make it simple? And so you could also, with the larger families, how do we make sure that you use what you have to make as much as you can for your family?
Great. Well, thank you very much for that, and I will follow up with you. I also sit on the Agriculture Committee and Agapropes, and I'm a little confused about the whole SNAP benefits or food box choices. So I want to dig in a little bit about that and anything we can do in cooperation with the USDA just to make sure that all the aid that is coming in, to deal with food deserts, lack of available healthy food. I mean, it's, as you said, this is nice that we're doing some pilot projects here, and hopefully we'll get some good information that helps to inform us going into the future. But with the challenges that people are facing based on health-related disease, we could do a lot more. So we'll work on that. But thank you very much for the work you're doing on it, and I'll yield back.
Mr. Zinke.
Thank you, Mr. Chairman, and I want to say thank you. You asked me what you could do to repair relationships with the Great Blackfeet Nation. Thank you for coming out. I think that the relationship began to repair itself, and thank you for everything. As you know, when you're out there, we talked about I don't want to rehash what happened with the Blackfeet Nation and IHS. I think we all agree when we look at what happened, it was atrocious. Moving forward, a bipartisan way, this committee and this body funded the $20 million necessary for a youth center in Browning. That is funding, it's underway. And what we talked about is a commitment on the IHS side to make sure that facility has a nurse practitioner there, and that position is prioritized. So I'm asking you is for your commitment, make sure you honor, if you would, your commitment. I think as we all recognize, on Indian nations, we have always not kept our promises, but in this case, your promise and my promise and this body's promise and this House's promise, I think has been met. So if I can have your assurance that position will be prioritized, and we'll do our part on this side as well.
Thank you, Representative, and thank you again for taking those steps to help me work with the Blackfeet Tribal Nation. Absolutely, I think we have really good examples of what we are doing out in Indian country to collaborate more with tribes and not necessarily, we've got to be listening to the tribes on meeting their needs versus what we think maybe their needs are. And so moving to those types of strategies and being able to maximize the resources that we have, having a nurse practitioner in a youth facility is the best thing that we can do, because most times those kids are probably not coming to the healthcare facility anyway. So meeting them in their space is absolutely the place that we should be. Yes, thank you.
I think it's particularly helpful for young women that have difficult choices, because sometimes the school is not the right venue to seek help, or the IHS facility. So and the tribe agrees, and thank you for that commitment. Next is the fentanyl. I don't think the Montana tribes are any different than many. We have a fentanyl crisis across, and it seems to be hitting the tribes at a disproportional rate. When I was secretary, we formed a task force to do drug interdiction in coordination with the tribe, always, but it consisted of the FBI, it consisted of law enforcement under Interior, which is significant, but those operations, undisputed, were helpful. On IHS, how much are you seeing of fentanyl, and what proportion of, do you think, a guess, of fentanyl-related issues are costing IHS? It's a big question, but how big of a problem is it, and can you put a monetary cost on what is costing IHS?
I don't have, and I'll circle back with you on the actual cost of that, but I do know that whether it's a dollar value or a family impact value, it is high in terms of the impacts to our tribal communities that are being impacted by this. I will say, though, that we are doing more collaboration with Department of Interior with regards to law enforcement. What is our role? What is their role in this type of space? What can we do in tribal communities that help us leverage? One of the requests and conversations that we're having right now, for example, is in their detention centers or in tribal jails. What is the health role in that? And so over the years, it's always been, it's a BIA role versus the IHS role, kinds of things. So we need to come together on that to make sure that we're addressing and doing, again, better coordination for that patient or that individual while either they're incarcerated or in the care that they're in right now. In the Gallup, New Mexico area, again, there's a lot of work going in that area, which I think is a great model where we are looking at the statistic, using data to help us drive the use of not just fentanyl, but alcohol and other drugs that are in that community area, but using a state, a federal, city, and county approach to it, and where they're building a system, again, that allows us to deal with the issues versus just incarcerate people because they're doing this and that. How do we get to the issues of the individuals that need the care that they had? Again, that is comprehensive, but we need to be looking at that. I was also out at the Crow Nation about 2 months ago, meeting with them, with the Attorney General of the United States, and we talked about that. Again, that's dipping into the missing and murdered Indigenous people, but the concept is the same. How do we build systems, and not just health, and not just the justice part, and how do we bring it together to make sure that everyone is informed of these issues that are happening across the country? And we do need the data that helps us build that. We do need to make sure that our teams at the local level understand and have the information they need to act when we need to act.
I look forward to working with you to make sure that the multiple agencies talk to each other. We don't get so stovepiped that we can't get out of our way. So, and thank you, and Mr. Chairman, I yield back.
Thank you, Mr. Chair. You know, I was thinking as you were going through the numbers and as we were all, I guess maybe it is me, started again. But okay. You're magic. You are magic. Okay, we're done. You know, when you were going through the numbers and what this committee has tried to do, and I take it a step farther and say in a nonpartisan basis when it comes to Indian country, there are two things that really impact what we can do to keep those tribal obligations that we have, and also some of the obligations that we have to our national parks, our water, our public lands, and that. There's two things that PILT payments coming out of this committee, which is the payment in lieu of taxes, never used to come out of this committee. It was dropped in before I served on this committee, before I got elected to Congress. The decision was that wasn't a mandatory payment that needed to go to the counties and those local units of government anymore. Somehow it was the Department of Interior's, this bill's obligation to do it. Medicaid, Medicare, other health things in this country are all mandatory, but for some reason Indian health is not. And there is resistance to doing that, but we together, and I was so glad that Ms. Pingree, while she was chair, was able to do the advanced appropriations. That saved lives. We were close to another government shutdown that saves lives. So I think, you know, we still need to have conversations with our leadership, with the administration. These are big picture things that I think people need to come to the table and really lay it out. Why this committee, and why these two things that are mandatory are thrown in here, and it keeps us from doing the job that we want to do, not only for Indian country but for people when it comes to public lands and water. I wanted to ask you a little bit about and one other thing. So the loan payment thing that you were talking about that's different, could you provide the chairman with that? You know, we're all lobbyists here on this side talking, and it's probably something that we might be able to easily fix. It's just an oversight. So thank you for bringing it to our attention. When you were talking about how to do the workforce part of this, one of the things that I heard you say is going to Morehouse, one of the African-American higher education institutions, an HBCU, which we fund some money into that too. When you're doing this, what has been the selling point when you talk to doctors or colleges or universities? And then what about the graduate medical training programs as people come out of the Department of Defense hospitals? Not all of them are, some of them are wearing uniforms and they will have an enlistment, some of them won't. As well as the VA, we have fewer and fewer and fewer teaching hospitals. So tell me a little more about working with teaching hospitals and what should we be doing in that regards.
The one thing that IHS must do a better job is talk about IHS. I think that as I travel across the country, there's people that have never even heard about Indian Health Service. So what do we need to do to get out there to really market Indian Health Service? Number one, we need to do that because there are many opportunities. Like we said, over 600 facilities across the country that the Indian healthcare system operates. Moreover, we are now the 17th largest healthcare system across the country, the Indian healthcare system, IHS tribal and urban programs. So we're competitive. We should be competitive across. But the collaboration that we're doing with the Veterans Administration is critical. I have worked, again, extensively with them, that they've had some really good, promising changes that they've made on the recruitment side. And what are they doing? When we dig into it a little bit more, again, these opportunities that they have with Title V and Title 38 are some of what they can do. They have a lot more flexibility and to be able to get in front of things versus the Indian Health Service and where we're located right now. Streamlining those application processes is so important right now. It cannot take months and months for us to clear people to get through our healthcare system. Some of that is our problem, but some of it is just the system that we're trying to work into. So that's another thing. And then the last thing I would say is that within HHS, we are the only healthcare system within HHS. And systems were not built for healthcare systems at HHS necessarily. So we're constantly trying to come up with creative and innovative ways to do our jobs, but we're having to then use, we have to build the systems to try to track things that we're trying to do, and that makes it immediately inefficient. But the collaboration that we can do more, whether it's with Morehouse, whether it's with the Veterans Administration, or even our tribal partners that now some of them are ahead of us, and like Cherokee Nation, for example, having a medical school on tribal lands, that's where we need to be saying, send our people to. Navajo Nation over the past years have negotiated with the University of Arizona that says we want so many slots for our native students to be first in line for medical school. So those types of things we need to lean into more and really make sure that we are part of those conversations as well to foster students that want to go.
I'd love to talk to you more about the University of Minnesota because they're doing a reconciliation right now. For some of the land and working through the state, even though it's a land grant institution, and we have a large medical school there too, along with 11 tribal nations, 11 tribal nations in Wisconsin, so there's lots to draw from. The last point I just want to touch on, and when we roll out the Affordable Care Act, one of the things that was in it was First Foods. I was part of the Native American diabetic, emphasis we were doing, for healthy eating, healthy outcomes, know your numbers, all of that. I visited a couple of tribal nations and healthcare facilities along, and it was like, rice, fish, buffalo, those types of things. So I'm interested in, what I can do to work with you, Ms. Pingree, on figuring out how to get this First Foods in. It was hugely popular. They had nutritionists out there. They did it multi-generational with grandmothers, and grandfathers with their grandchildren cooking together, coming up with the old recipes and, even going out and hunting and gathering for things. So But when those dollars are gone, sometimes that program goes away. And I don't know if you have the numbers to find out how successful that was, and maybe that's something we could reinstitute. Last thing I'll just close with is, when you think about the number of Native Americans proportionally that serve in our military, for our VA, for our DOD, to be reaching out in ways that we can to honor back their service through health care is something that Mr. Inslee and I both serve on the Defense Committee, would be happy to do. And we're trying to get more first foods occasionally introduced into our mess halls, too, because the number of Native Americans that proportionally, far in by ways, outnumber any other group that serves this nation. And they do so even though we haven't kept our promises. I yield back.
Thank you, Mr. Chairman. Thank you all for being here today. I live in the Dallas-Fort Worth area, and there's 20,000 tribal members in the urban area of DFW. And Zinke strikes again. And those in my district and the surrounding Dallas-Fort Worth area are served by the Urban Intertribal Center of Texas, which is part of the Urban Indian Health Institute. Can you explain how the research and data that's collected through those programs and the tribal epidemiology centers helps to better serve American Indian and Alaskan Natives?
Thank you. I was just out there in Dallas when they were reopening their healthcare facility out there, so that was great to be able to see what they do. It is pretty impressive when I travel and visit our urban programs, all of them. The resources that IHS gives them is so little, but they make it work somehow, and they do some amazing things out there in our urban communities. With regards to the data and the studies that they're doing, this is something that we also are leaning in to try to do a better job at streamlining how we maximize the data that is gathered, not just at our urban facilities, but across Indian country, looking at making sure that we are doing the research that we need to be able to tell our story better, and where we're making strides and where we still need to do more. On the data side, there are challenges, though, that we are working through. HHS last year did a consultation with regards to data and research and trying to figure out how we make sure we maximize those resources. I know in talking with our urban programs, this is something that they need. They rely on, especially in the Dallas area, that there are the number, the 20,000, that's the same number that I'm hearing about, that they need more facilities, they need more services to be able to meet the needs of those people in the people in those areas. So, but there are more that we can do in the research area and also the data sharing area as well.
Okay. I always am fascinated by the chairman who's been doing this for a long time, and I'm new to this subcommittee and have no tribes in my district, so I appreciate the ability to learn about tribal issues and the food insecurity issue, which I think has become pretty vogue over the last 5 years, which I'm sure it seems like a somewhat amorphous term. My question is kind of threefold. Is there malnutrition in some of the tribal lands that we see? Are there tribes or areas that have a higher susceptibility to diabetes? And are those in correlation with food deserts and a lack of grocery stores? Because a year ago we talked about how the difficulty in the legal and insurance realm doesn't allow somebody to put a grocery store that's got fresh fruits and vegetables in a res, and they have to travel. That's a wide-ranging question. If you can answer any of it, it would help me.
Yeah, I'll give you a couple examples. I've visited Alaska several times. I think the one of the things that I remember about one of my visits to Alaska was the fact that a tribal community in a small village that always relied on salmon and for fish didn't have those anymore. They don't have those abundance of fish anymore. And so, what do you do? And especially in again, the very remote locations of Alaska, where, again, the only way, if they can't get what they would normally get there, like the fish, then it has to be flown in. That's the only way that it can come in. And then you're hoping and praying that the flight will be on schedule. You're hoping and praying that there's no delays, because if there are delays, anything that you're buying fresh from the city is not going to be fresh when you get it to the tribal communities. So understanding that, and that's just the food. You're thinking about that on the healthcare side, and you're talking about how does that work. I was out in Minnesota, the same thing. The challenges that they're having with what they normally used to be able to have abundance of their traditional foods is not available anymore. It's not easily available anymore. So whether it's a food desert, but that's where they're going, where people's traditional, and I worry, and that's where it goes back again to the data and the research. What happens to the tribe that always relied on salmon, which is a healthy food, for their primary food, and it's not going to be there anymore. They're saying that for big animals too in Alaska. And again, relying on the rice and what our tribal people in the Minnesota area are accustomed to, that's not there. So as we move forward, I think that we're going to start to see more and more of these. But it does go back to these innovative ways that what else can we do in this space to make sure. And I think that many of our tribal communities were stretched to think about ways to during COVID. You know, again, we had those same challenges. So using some of those things that we learned during COVID to try to figure out how do we, number one, share that information. How do we, number two, use those foods that we have available to us to make it as healthy as we possibly can.
Is there, and forgive my question here, I may just not know, a commissary system? So no matter where you are, you can be in Virginia Beach and there's all kinds of great grocery stores around there, but we have a commissary that has discount prices for military members and veterans to go shop for groceries. Does any kind of that system like that exist anywhere in the tribal system? And if it doesn't, would that be a decent way to avoid the food desert issue that we have?
Thank you for that. I think we're certainly open to anything in terms of making sure that we improve what we do. But, when you talk about like this small village in Alaska, if the commissary is still going to be a ways away and you still have to fly that food in, then that's the challenge. The cost of that. The people have to pay, not only do they pay for the food, but they have to pay to transport it in. So if it's healthy, it's good, and they do have what I guess we could refer to as a small commissary. But the prices in those small commissaries, it's not even imaginable to me when you're talking about diapers and when you're talking about formula and when you're talking about just the basic needs that a family might need. The prices are outrageous.
Like I said, the DOD offsets the price of a lot of those things, and so that's kind of what I'm suggesting is that there be a commissary system for tribal lands, especially where we've identified a food desert, where the government will offset. We spend a lot of money trying to figure this problem out. The government will offset the cost of some of these issues, so it wouldn't be a extremely high cost. It goes, hey, we recognize where we're going, and we can offset the cost of some of these goods and services, these goods at a grocery store that is assisted by Interior and this subcommittee. Just an idea. I'm sure my time's expired. I don't see a clock anywhere, but I yield back, Mr. Chairman. Thank you.
Those ideas, that's something I hadn't really thought about, that may be worth investigating and stuff, so I appreciate that. I was always interested that when I found out that Native Americans had the highest diabetes rate of any subpopulation of Americans, and that what they were finding is getting back to the traditional foods is the best way to treat that diabetes. It's amazing, and that's what tribes are trying to do again. Mr. Harder.
Thank you so much, Mr. Chair, and I'm going to follow up on exactly that point. I'd love to hear a little bit more about the special diabetes program within IHS. It's a big deal in my district, as it is in many districts across the country. About half of my district is diabetic or pre-diabetic, and of course, as the chairman mentioned, it's even more common among our Indian population, especially Buena Vista Rancheria and some of the other places of tribal country, Indian country around our community. And it's been a real focus of our office to do work to try to make sure that we're focusing on some of the prevention efforts, trying to make sure that we have healthy food available to folks, and also some of the treatment. Can you help me understand how the special diabetes program has changed over the last couple years, and the $260 million that you're looking for this year? How exactly will that be invested, and what type of innovation have we really seen there?
Thank you very much for that. I love our special diabetes program, and it's just the amount of work and the innovation that has come out of that, and the data that supports the work that is coming out of that program is actually equating to, again, the prevention that is happening in Indian country. We look at, again, as many of the places that I visit with respect to, again, how do we just do a better job at eating? Moreover, how do we make sure that our kids are getting outside? You know, I was just out again last week out in Indian country, and they're building these bike units, these bike ramps that they're using these resources so children can get outside and ride their bikes and have in a safe place to be able to make sure. And these are all sort of temporary modular units, if you will, but they were pretty impressive to see that there's a lot of creativity out there. I think also looking at the food part, it really focusing on how do you take what you can go to a grocery store and simplify it. And say, if you're cooking for, again, most of our families are multi-generational. So you're talking about a grandma and then maybe a toddler. And how do you find foods that everybody can eat? And so trying to make sure that, again, the menus are being built for those tribal communities, by the tribal communities, and utilizing, again, our elders all the way down to the young people. How do we do this? So that's what I see, and I've seen that absolutely change over the years, and making those funds permanent, I think, is absolutely something that I've seen the data. I've seen the progress, probably one of the best examples in Indian Health Service about prevention of diabetes, prevention of heart disease. Again, all that equates to less cost, less hospital visits, and those kinds of things.
It's great to see some of the evidence around how that saves us money. You know, an ounce of prevention is worth a pound of cure, and I think the special diabetes program is estimated to save Medicare over $500 million over the next 10 years. So congratulations on the good work and on all the evidence that backs up that it's working. What is the breakdown of how that program is operating in the field? Do you have a sense of how much is on prevention, how much is on treatment? What are the programs that have really had the highest ROI? And what do you think the unmet need is out there today?
Thank you again for that question. With respect to the diabetes program, a majority of those funds are going to tribally operated programs. So again, each tribal community has to have the resources they need to build what is best for them. Again, not the government or not Indian Health Service saying it needs to be this way or that way. But those decisions are made locally in terms of what do they need to do to, as I said, very creative things in terms of just basic things of upgrading their kitchen so they can do more education, for example. What can they do in the space of weight loss? What are the activities there? What are opportunities that they can do in there? Infrastructure. Again, many of our facilities don't have the infrastructure where people can go to exercise, if you will, or go to places, especially in Minnesota. It gets very cold there. There's got to be a location for people to go, because you can't just tell people go exercise and go move around outside. It's just not practical. So again, tribal governments making decisions for their people of what is best is so important. So majority of the diabetes funds goes out to Indian country. Probably, I would say 90%. The remaining is associated with our IHS operated programs. That 40% I was talking about, that's still IHS. Still very important, but I see tribal governments, tribal leaders, tribal communities making the decisions for themselves and their community, because we're not all the same, is what works best.
Thank you for that, Director. And one last question. Do you see any unmet need? Are there applications that are going unfilled? How do you quantify how much demand there is for this program that you're not able to meet with the current budget?
Yes. So the one thing that I would see as a barrier is that this funding is going out in grants. So I understand that there's always a need to make sure that the money is being spent wisely. But if the money were to go out in either our contracts or compacts or a different method, again, that gives them more flexibility to do that. So when you're running a grant, then, you know, you're sort of having to limit what you think you can do versus what I've seen other tribes do when we do give them the resources, so they make those choices. There's more flexibility there. So the unmet need is still that we still have diabetes numbers going up. We still have opportunity to build those prevention programs that have not quite been met by the budget that we have.
Thank you. Yeah, I yield back.
Thank you. Something came up that was kind of interesting that you mentioned. You said that the Navajo Nation reserve seats at Arizona, University of Arizona Medical School?
Yes.
Because that's important that we get tribal members into medical school, dental schools, nursing schools, those kind of things, because they're more likely to come back to their reservation and provide those services. And so that helps with the staffing issue that we have around here. And it got me thinking, in Idaho, we have a program called Witchy and Whammy, 2 programs. One of them is for dental students, one is for medical schools. We can't afford a medical school or a dental school, so we reserve so many seats at the University of Washington, as does Alaska, Montana, Idaho, and then at the dental school at Case Western in Omaha, we reserve so many seats for Idaho dental students, and the state pays for the out-of-state tuition when a student gets accepted to those programs. And most of the time, those students graduate and come back to Idaho. And it's a lot cheaper and makes sense for us to do that rather than try to go out and build a medical school or something like that. Does IHS do anything like that, or is this individual tribes doing it?
A majority of the time, it's individual tribes that are doing that, making those types of commitments that we do. But we also pay for long-term training for some of our providers if they want to go. Like if we have a dentist and he or she wants to get advanced schooling and whatever, we do pay for that. In return for they stay with us for a longer period of time. So there are those opportunities on that. I know that we work very closely with the University of Washington. We can do more to make sure that we're tied in very closely with these universities out there, OHSU out in Portland, Oregon, Oregon Health Sciences University. Those are the ones that I know. But I also realize that many of our tribes and our tribal organizations are already tied in with these universities that are close to them, so they can tap these resources that are available.
Well, and for a large tribe like the Navajo Nation or some of the others, that would probably be easier to do, but you got some small tribes that probably don't know how to go about that or whatever. I think that's something we ought to explore, of talking to medical and dental schools, nursing schools, whatever, and seeing if IHS can be active in reserving seats for tribal members at some of these schools, because I think that would help us address our staffing issue and stuff. Now I want to ask another question that I told you I was going to ask. This is not a criticism of IHS or anything else, but I have heard from several tribes that they believe we would do better to eliminate IHS and give direct appropriations to the various tribes. And while that might work for some tribes, other tribes it might not, because all tribes have different needs and they have different sizes and different abilities and all that kind of stuff. But what I hear is that they could, because of the overhead costs that IHS has, they could do better delivering the services directly to their tribal members if they had a direct appropriation to do that kind of stuff. That might be true for some and not for others. What my question is, and I'm not prejudging this, I'm trying to find out, I want the same thing you want, as does this committee want, and as the tribes want, and as is to deliver the best health care that we can for the dollars that we have to Indians across this country. Is this model that we're currently using the best model? What is your overhead costs? And is there a different model that we ought to be looking at? And I'm not suggesting that we would do it this year or anything else. I'm looking at the next 10 years about how is the best way to do this. So I'd appreciate your thoughts on that.
Thank you for that. And I thought about this a little bit after I left your office yesterday. A couple things that I would say is certainly the Indian Self-Determination Act allows for tribes. As I said, 60% of these tribes have made those decisions and said, we're going to run our own healthcare program. So a majority of those funds, or most of those funds that they have taken from the Indian Health Service, 40% today still say we want IHS to continue to.
Let me ask you on that. If you were a tribe that you were upset with Indian Health Services, and you said, we can run our program better and cheaper than going through IHS, could they choose
Absolutely.
to go outside of IHS and deliver the services themselves?
60% already do.
Okay.
Yeah, so the Indian self-determination allows them to do that.
Right.
And then so what remains are the dollars that support the remaining 40% of the tribes. So as they continue to choose to go on their own and be self-determined, then IHS will keep shrinking like it is right now. So the overhead costs that we're talking about here is minimal in terms of the 40% of the dollars that we have left. A majority of those are supporting these healthcare facilities that we have out in Indian country. So those are staffing dollars. Of course, that's always the majority of the funds that IHS is asking for, staffing dollars and operation of healthcare facilities. So that's already happening, and eventually, you know, the theory was way back when these conversations were had in the late 80s and early 90s, was that eventually tribes would be operating all of their own healthcare system. At that point, then you would have only what we would call residual, or what are federally inherent functions that would remain of the IHS. So I believe to some degree we're already going that direction.
Okay.
Mr. Chair, can I ask a question on top of that?
Yes.
I hear what you're saying, and I'll just speak not for the tribes, but for myself. So I look at Net Lake or Fond du Lac or Boys Fort up in the northern tier. They don't have the population to support a hospital. They're far away from other hospitals. So one of your early comments about transportation becomes really important. Technology becomes important. Having different levels of medical ability and flexibility within the systems becomes important. Then I kind of look into, and that would include Red Lake too. And then I look at, like, you know, White Earth, Leech Lake, kind of in the central part of the state, not too far from Brainerd, not too far from Bemidji. You know, it would be having those hospitals then, because here again, not enough to support a hospital. And I'm talking hospitals right now. Having a hospital, having a contract with payment and support and everything else, and transportation. And then here again, having healthcare clinics that are really state of the art. So I like your idea about thinking into the future. And that's going to be a challenge because you run into different cultural appropriate healthcare even within tribal nations. But also just in my state alone, I'm thinking of all the different size tribes. And then when I look at the land mass, and we've had the Dakota tribes in here talking, a huge land mass spread out all over, extreme poverty. So transportation was something that becomes critical in delivering healthcare. What's your transportation budget? I mean, do you really have anything in there? I know when I was in New Mexico, it was in New Mexico. The hospitals there they don't deliver enough babies, and we were losing moms and babies, so they plan a C-section and all that. So, you know, but who pays for that transportation? Who pays for that health care cost for the family to have somebody be with them? Because as we're thinking about this model, I'm thinking about new lines of what you're going to have to add. And I love what you said, because it's going to look different. but and it's going to look different everywhere. So in my state, I see 3 or 4 different models alone.
Absolutely. Thank you for that. Again, I'll add to that, is that in many of these very rural locations, particularly in your area, because I visited up there, we're seeing where the other facility or other healthcare systems are not successful. So our tribal health programs have now become the safety net in some of these areas. So they're seeing everybody in those communities, not just tribal people. They're seeing more and more people because they're the only game in town, if you will. With regards to transportation, this is huge for us right now. I have met with the Department of Transportation and looking at a whole federal approach to what is it that we can do to address this, where we know that they have programs that tribes can tap into in terms of maybe transportation systems in tribal communities and so forth. And then how do we leverage that? How do we make sure, again, that people can get what they need? Moreover, as I was talking about earlier, the improvements that we've made to purchase and referred care, we've now integrated travel into that because it wasn't there before. So we're bringing, again, more flexibilities that tribes have the latitude to do what they need to do. And we learned this as a result of COVID when we were flying people out and we're sending people all over the country, but no way to bring them back when they were ready to come home. So that was a whole gap in our system. So we're trying to look at how do we at least provide that flexibility for tribal communities to make sure that people can travel here and there. We've even gone as far as to look at how do we address ambulance, for example, EMS program services, almost one of our lowest funded programs, but has become so critical in Indian country. When we talk about fentanyl, when we talk about these issues, the safety issues for everybody, not just the patient, but the drivers and all of that, how are we looking at that more holistically to make sure that we're doing everything we can? The transportation, again, I'll go back to Alaska, where they have told me that they don't either have flights anymore or they have been significantly reduced. So how do you take a patient from point A to point B for the services that they need? And so trying to look at all of the strategies of looking at the whole healthcare system, not just Indian Health Service or not just the BIA, but Department of Interior, EPA, all of these programs is what I've been working with to say, hey, there's got to be a full government approach to Indian country when we're talking about health. And so I think taking a little bit different look at how we do that instead of everybody being in their own whatever is what we need to do so everyone is aware of this.
Thank you. And all I'm trying to do by asking this question, and I'm going to ask the tribes when they have tribal days here and stuff, is that I hate to say think outside the box, but we need to be thinking about what we want Indian healthcare services to look like 5 and 10 years down the road. Because the decisions we make today are going to be making those. And none of this stuff would be easy to do overnight. And should we be moving to a different model or modifications to the current model that we have? And could that deliver better healthcare service to Indians? And I know that's what we all want. So I appreciate you looking at that. And it sounds like you've been thinking about things that can be done even with Indian Health Services to make it operate better. So I appreciate that. One other question. Modernization of the electronic healthcare record system continues to be an extremely significant cost driver for IHS. President's budget request includes $245 million increase for the total of $435 million for FY25 for electronic healthcare records. That is more than all dental health programs, all mental health programs, and all alcohol and substance abuse programs, and nearly doubled all preventative healthcare programs combined. Can you please justify this investment? How will this help provide better health care in Indian country? And as you know, Veterans Affairs has endured significant challenges transitioning to this new system that have contributed to patient safety risk. What is IHS doing to provide timely and adequate training to prevent some of the issues that the VA has faced during this transition? And what conversations have you had with VA to learn from their challenges?
Thank you again. Another very important topic at the Indian Health Service. I understand and hear that this is a huge price tag for the Indian Health Service, but the price tag of patient care and safety and all of those things are equally important as we're moving forward with this. When we look at electronic health record, our system is more than 40 years old. So while we have made investments over the years, we have never made the kind of change that we need to make today. And again, when we're talking about complexities of healthcare system across the country, let alone Indian country, and where we have very remote locations, where we have limited connectivity at times, and all of these other challenges, finding a way to allow us to move forward in this space. The $27 million decrease in 2024 was a huge hit to us because we are on a schedule. We want to make sure that we deliver to Indian country the best healthcare system for we're documenting patient care. Why is this so important? Because our veterans now, there's no easy way when a veteran comes into an IHS facility and they have to go to a VA facility, that information is not being shared. When we talk about the opioid issues and mental health issues, there's no way to transfer to say, hey, there's a patient that saw me yesterday, I need you, I'm now referring them to you. It's mind-boggling to think that we don't have enough of a system that allows us to do this. What I've seen tribes do, and probably most of us experience that, we can text with our provider. Our system doesn't allow us to do that, so we need to move to a system that allows us to have more direct contact with our providers, or with our patients. With regards to the costs, we want to stay on schedule with the costs. The money that we're asking for, I realize, is a lot, but it's a huge game changer for Indian country. And we've been working very closely with all of our tribes to make sure that they are informed of every step that we are taking. Moreover, the award that we made late last year to General Dynamics was not challenged by anyone, unlike some of the challenges that you raised about the VA. And so we're learning from the VA. We're working very closely with the VA, and some of the things that they did that we have done totally different. We went out on a wide competition to find the best contractor that we could have. At VA just went with a sole source, and so that's one of the challenges that they had. We've communicated broadly with our partners across Indian country of what we need, what will it look like. We're not going to agree to make any changes to the electronic health record until it is in place. So we're not looking at trying to, come up with with something that we have to live with forever. But we want to make sure that what we build is going to work for us, and then we can look at how we make changes down the road as we move forward.
What's almost mind-boggling to me is this problem. You would think it would be relatively simple. I know if I go down, I had my hip replaced just recently. They took x-rays of it here at GW. My orthopedic surgeon is in Idaho. He called up the x-rays from GW and looked at them. It's mind-boggling to me that this is as complicated as it is to get, whether it's defense health records with the VA or it's amazing. And we've been working on that. I know Betty has on the Defense Committee. And I know it's amazing how complicated it seems. Ms. Pingree.
Thank you, Mr. Chair. Actually, okay. I'm really pretty much done with my questions, and my last question was going to be about the electronic health records, so thank you for bringing that up and covering it. And you and I had an opportunity to talk over many of the things that you're talking about today, and thank you for going over those again, because it is so critically important that you go into this eyes wide open, that you do the thorough research you're doing now, that you learn from the mistakes that the VA has made. And I sit on Milcon VA, so I've listened to that for quite a long time now about, the challenges that they've faced. So it's helpful to hear you go through, is it about the sole sourcing? Is it about changing how the system is going to work? But I think, and I agree, it's mind-boggling that that you're dealing with systems that are, over 40 years old, and that you have no ability to do this. And particularly in light of the earlier question about, you've got some people in Indian health centers, and some tribes are working on their own, and then obviously, people move between places, and just the idea that there aren't easily exchange records is really tragic for people's health care. So I'm glad you're tackling it. I think it's going to be very hard to deal with the cost and just make sure that it's available, because you have so many great needs, and it's going to feel frustrating to say, like, we have to put all this into a computer system when you want to be giving patient care, you want to be hiring more practitioners. That's just hard. So I think the most important thing will be, working really closely with you as you're going through this transition process. I think the one thing we don't want to have happen is, 5 years down the road, somebody saying like, oh yeah, we spent all that money and it actually didn't work, or the things that you might learn in retrospect. So sort of following this closely and monitoring it and thinking about the pitfalls along the way. So hopefully, if there are challenges that we're not anticipating, we can get ahead of them and figure it out as we're budgeting it. So I will just say, we're all committed to working with you and making sure we get this level of modernization done. And yield back. Thank you, Mr. Chair.
Thank you. Mr. Elsey? None? Ms. McCollum?
I want you to just leave it on. There you go.
So I would be interested if you would provide to the committee, because I know you've been working on it, your maternal child health statistics, both for urban and for rural. And I mentioned a little bit what I saw when I was in New Mexico. You need to deliver a number of babies in order to have something. I was in one of the Dakotas, I won't mention which one, and they were so excited that they were maybe going to start delivering babies again. And I asked the question, how many babies do you think you deliver? And it was well under 30. So I don't like the idea of planned C-sections. That's something we're definitely trying to get away from. So what kind of ideas in that you have for health, maternal safe delivery, and what we're doing on that? I would, you can get it back to the committee unless you want to make a brief comment. But it's a big topic. And it's a tragedy what continues to happen, and it happens to Native Americans in urban settings as well too. I was just with our family center in St. Paul.
One last question. One last question before we adjourn. And again, thank you for being here today, and I want you to know that this committee is committed to helping you do your job and making sure that we get the care for our Indian brothers and sisters that they need and deserve and are entitled to. And so if issues come up, and contact us. Let us know. We want to help. This year we went from, your proposal is for mandatory funding for Indian Health Services for coming years. And we did advanced appropriations, and that, I guess the main reason behind that was so that when there was a threatened government shutdown or whatever, services were suspended for everything else. We didn't shut down Indian Health Services, right? And to me, that was a smart thing to do. Mandatory funding is, I guess my question is, mandatory funding at what level? How do you determine the level? And what does mandatory funding mean in terms of, we don't really know what is going to be spent on health care next year in the Indian Health Service. We don't know what the need's going to be, et cetera, et cetera. How do we determine that to make it mandatory, and why is that more important than advanced appropriation?
Thank you for that question. Again, first of all, I cannot say enough about advanced appropriations, which is a game changer for us this year, and to be able to, again, have tribes and IHS be able to plan and have a predictable budget. But we believe that mandatory will grow for us at the way that we need it to grow. It's already built in for inflationary costs that are in there. And the expenses that we need for staffing and those sorts of things. So it's critical in that area that we believe the growth over the years, over the 10-year period, will be significant and more than what we're going to see in the discretionary funding source. So we're needing that. We're needing the mandatory funding. When I talk with tribal leaders across Indian country and even within HHS tribal consultation. The price tag that tribes tell me is that $63 billion is what we need to fully fund the Indian Health Service. The gap is large and huge when we talk about this, but it's also very real when I travel out to Indian country, when I meet with tribes on just how do we do this differently? How do we do it better to be able to meet the needs of our people? We believe, again, because of the automatic growth that's incorporated into mandatory funding, that will be what will build that foundation for Indian health care across Indian country.
Well, I don't know how they came up with 63 billion. I would be interested in knowing that, especially when our entire budget in this interior is about, what, 38 billion? Yeah. So, I mean, so if it's just money, and let's say that they said they needed next year an additional $3 billion. If we appropriated it at the advanced appropriation at a $3 billion increase, it wouldn't make any difference whether it was mandatory or advanced appropriation, would it?
I'm going to ask Jillian to
Okay.
work on that.
You know, I think the point you're making is right on, sir. I think a key component of the mandatory proposal is also being able to have that 10-year view of what the budget is going to look like. And when we talk about what is the future of the Indian health system, when we talk about, you know, what do we need to have to be able to meet that obligation over that period of time, being able to plan for a 10-year funding window and know what your resources are going to be over 10 years would frankly kind of revolutionize the way that both IHS and tribal health care and urban Indian care is being provided right now. So I think, you know, we are already looking at costs that are well above what we know can be achieved in the discretionary space. EHR, we just had that conversation. We have backlogs for facilities that need to be addressed that are in the billions of dollars, again, very difficult to achieve in a discretionary budget. But in addition to that is really the ability to look to the future and plan to the future through that clear 10-year budget window of what we would expect for resources.
Okay. Well, I appreciate that, and I know that getting mandatory funding is like becoming a tenured professor. It used to be that about 70% of the federal budget was discretionary spending and 30% was mandatory, various programs. It's just the reverse now. It's about 28% discretionary and 72% mandatory programs. As we move more and more, I think you're trying to get us to not have a job anymore, because as we move more and more into mandatory, we won't need an appropriations committee. It'll just automatically go to these different agencies and stuff. So I get very concerned about moving more and more programs into mandatory funding, although I understand the need and the desire to do that. But that's certainly something we will look at along with the other proposals in the budget. And I would be very pleased if we can keep the advanced appropriation, because I think that's been very, very important, and I'm pretty sure we'll be able to do that. So thank you for being here today. If there's no other questions, appreciate it very much. As I said, we really do want to help you do your job. And if there are things that we can do that make it easier, or things you need us to address, be sure and get us the difference in how HRSA is treated on tax-wise and Indian Health Services. That might be something that we can fix in our bill. But thank you for taking the time to join us this morning. I think it was a productive discussion, and we look forward to working with you over the coming months. Committee stands adjourned.